Hello, this is Brittney Lodato, Administrative Director with JDJ Consulting. Today, we're going to discuss keeping the infection out of the injection, a safe injection practices in service. Before we begin, I have a quick disclosure I'd like to read. This presentation was prepared in conjunction with the New Jersey Department of Health Communicable Disease Service, who is a partner in the CDC's Injection Safety Initiative. The New Jersey Department of Health does not receive compensation for this presentation. This presentation is not a requirement by the NJDOH. Today, we're going to discuss the increased focus on healthcare-associated infections, otherwise known as HAIs. We'll also discuss safe injection practices, review outbreaks, and I'll provide some infection prevention resources. More and more, treatment is being shifted to the outpatient setting. Patients deserve to be treated with the same high, safe standards, regardless of the setting in which they choose to obtain their care and treatment. Growth and shifts in care to settings where infection control infrastructure and oversight may be lacking is one of the things that are contributing to higher rates of healthcare-acquired infections. There's concern because infection control programs are not robust in the outpatient setting as they are in acute care settings. There's no requirement for infection preventionists in a private practice setting. In addition, surveillance systems are not in place to detect infections in these settings, so sometimes they go unrecognized and unreported. The CDC categorizes healthcare-acquired infections as a winnable battle. This means that in a healthcare setting, a patient should never acquire an infection as a result of their care. By working together and adhering to strict aseptic technique and safe injection practices, we can be sure to prevent HAIs and make sure that our patients do not become ill. Let's take a moment to define injection safety. Injection safety refers to measures taken to perform injections in a safe manner for patients and providers. We often think about injection safety in terms of protecting the healthcare worker from needle stick injuries. When we talk about protecting the healthcare worker, we think about the Occupational Safety and Health Administration, or OSHA, specifically the bloodborne pathogen standard. Injection safety goes beyond that, though, and considers measures that will prevent transmission of disease from provider to patient and from patient to patient in the course of receiving healthcare. A lot of healthcare workers find it difficult to believe that patient-to-patient transmission happens in the healthcare setting, but as you'll see later, we do have several documented cases. So, overall, injection safety is a combination of OSHA and HAI prevention and patient safety. Measures taken to perform injections in a safe manner for both patients and providers are listed here. This includes not reusing syringes or needles on more than one patient or to access vials that are shared between patients. We want to be sure that we're preventing transmission from all people working in this setting. Safe injection practices are just one of the standard precautions, along with hand hygiene, personal protective equipment or PPE, respiratory and cough etiquette, and environmental cleaning. Here are some of the highlights of safe injection practices that I would like to stress. This looks like a list of no-brainers, but you'll see that breaches of just about all of these have occurred, and they lead to disease transmission and outbreaks. Take a moment to pause the slide and review these. This slide represents some of the common misperceptions that are heard from providers and healthcare professionals about injection safety. You can see that there's a wide range of myths and truths. One of the most common misperceptions is that if you don't see blood in the IV tubing or syringe, it means that these supplies are safe for reuse. As we've heard here today, all of these practices may contribute to disease transmission and are bad clinical practice. Bacteria and viruses are called microscopic for a reason. Just because you can't see them doesn't mean that they aren't present. I recommend pausing this slide to have an opportunity to read each myth and truth and make sure that in your healthcare setting, you're adhering to strict, safe injection practices. Here are some of the headlines from across the country in response to breaches, disease transmission, and outbreaks. These types of events erode public confidence and make patients less likely to seek preventative care services if they perceive healthcare as being unsafe. In order to understand how patients have contracted diseases in healthcare settings, you need to understand a bit about disease transmission. There are two general categories of disease transmission: direct and indirect. Direct occurs when you have a sick person in direct contact with a susceptible person. For instance, you have a person who's sick with the flu. The person with the flu sneezes on the susceptible host. The host subsequently develops the flu. Indirect transmission can occur without the source patient and the susceptible person ever coming in direct contact with each other. Disease is transmitted through contaminated equipment, contaminated medication, through contamination in the environment, or through the hands of the healthcare worker. This is the primary mode of transmission for blood-borne pathogens. Hepatitis B is a hardy virus and can live in the environment for a long period of time, up to a week. Here's some information about the hepatitis C virus. It's stable in the environment for at least 16 hours. And studies have shown that it can remain infective on dry surfaces for up to 6 weeks. The hepatitis B virus has a high viral load and is stable in the environment for 1 week or longer. HIV is not a hardy virus and generally does not do well in the environment. On occasion, it has been reported that HIV has been transmitted from patient to patient in the healthcare setting. Over the last few decades, we like to think of bloodborne pathogen transmission as a never event, meaning it should never happen. No one should be infected with hepatitis B, hepatitis C, or HIV as a result of the health care that they're receiving. In this 10-year span from 1998 to 2008, there have been 33 documented outbreaks in 15 states in these non-hospital settings. 12 outpatient clinics, 6 dialysis centers, and 15 long-term care facilities have been the environment for transmission. In this shorter time span of 6 years, from 2008 to 2014, there have been 44 outbreaks of viral hepatitis reported that are related to healthcare. 95% of them were in non-hospital settings. Here is some more information about hepatitis B outbreaks from 2008 to 2014. This is more information about hepatitis C outbreaks from 2008 to 2014. Now let's go over some basic syringe safety. I'd like you to take a moment to look at the following images. Discuss amongst yourselves what issues you see with the images and what breaches of sterility and safe injection practices you notice. What kind of labeling is occurring on these syringes? What objects are in the area that maybe shouldn't be? Do you see an issue with the labels on these syringes? Is there any missing information? Does the label appear to be complete? Again, take a look at what's in the field. Take a look at the labeling on the syringes. Although propofol seems to be a very clear drug, it is not the only drug available with a milky white substance appearance. In addition, there are several syringes filled with clear substances. In this picture, we see that a syringe is actually piercing the septum of a vial. At this center, this is how the vial was being stored in the cabinet. What is the main issue with that? Do you think that from an infection control standpoint, that's an appropriate way to store a syringe? Finally, take a look at these syringes found in a drawer. Do we have any way of knowing when the syringe was drawn or how it was being stored? Now let's take a minute to discuss single-dose versus multi-dose vials. Not all vials are created equal. Dozens of outbreaks have been associated with the reuse of single-dose vials and the misuse of multiple-dose vials. Single-dose vials and multiple-dose vials can come in any shape and size. Make sure that you're checking the label before use. Single-dose vials are approved for use on a single patient for a single procedure or injection. They lack an antimicrobial preservative. You should be sure to discard these after every use. You can see in this picture that we've circled and drawn attention to the label single dose. You can always look on a vial to see if it says single dose or multiple dose. Multiple dose vials are recognized by its FDA-approved label and can be used for more than one patient when aseptic technique is followed. They typically contain an antimicrobial preservative to limit bacterial growth. However, preservatives have no effect on bloodborne pathogens. Be sure to discard multiple dose vials when the beyond use state has been reached, when doses are drawn in a patient treatment area, or anytime sterility is called into question. Again, you can see that multi-dose is circled on the packaging and the vial. When is a multi-dose vial considered single use? The answer: when it's prepared in the immediate patient care area. When is a single dose vial considered multi-use? The answer: never. And when is a multiple dose vial, what is the main difference between a multiple dose vial and a single dose vial? The answer: multiple dose vials have preservatives, whereas single dose vials do not. Let's talk about outbreak. Not this kind, this kind. This is a sentinel outbreak. Many of these outbreaks are caught by clinicians who recognize that their patients have no traditional risk factors. In 2001, there were 4 individuals who were being treated for cancer but tested positive for hepatitis C. All received treatment at the same oncology practice. This practice was located inside of a hospital complex, but was not owned by the hospital. There was no oversight by the hospital. 613 patients were notified that they needed to be tested for hepatitis C. 99 of them tested positive. This outbreak occurred in Nebraska. The Oncology Treatment Center was pretty much the only place to go for this kind of treatment. When the cases were identified, the nurse was fired. However, a few months later, the physician decided that he wanted his facility to become what was known as a center for excellence. A team of evaluators came to the facility to observe practices. They found many more infection control breaches and instances of bad practice. They denied the physician's application for a center of excellence. During the interviews with patients, various infection control breaches were identified. One such was reusing syringes to access saline bags. After syringes were used to withdraw blood from the patient's catheters, that same syringe was used to access a common saline bag to flush the patient's ports. In fact, some patients noted that if they received their treatment early in the day, the IV bag was clear. However, if they received treatment later in the day, the bag was tinged pink with blood or particulate matter. The oncologist associated with this center fled the country and became a minister of health in his home country. His professional licenses in the US were revoked. The patients who were infected sued the physician and his practice and were awarded money. As far as patient outcomes, some of the individuals actually died as a result of obtaining hepatitis, not from the cancer they were being treated for. Some patients were treated, and one partner of a patient actually was transmitted the virus sexually. A notable outbreak occurred in Nevada at an endo center. This was a pivotal case that really focused attention on disease transmission related to injection safety breaches. In January of 2008, a cluster of 3 acute cases of Hep C infections were identified in Las Vegas. All 3 patients were noted to have undergone procedures at the same endo center during the incubation period. The outbreak resulted when anesthesiologists and nurse anesthetists did not follow safe injection practices during the administration of anesthesia. The medication that was at the center of the outbreak was propofol, which was used for sedation. There were two significant breaches that occurred. The first is that the syringes were reused for patients who needed additional sedation during a case. The second breach occurred when the single-use vials were reused on subsequent patients. To review, the anesthesia personnel started with a clean needle and syringe and entered a new vial of medication. The patient, who happened to be hepatitis C infected, was administered the medication, thus contaminating the syringe. The patient needed more sedation during the case, so the needle was changed, but the syringe was reused to enter the vial to get more medication. Now the vial was contaminated because the syringe was contaminated. For a subsequent patient, a new needle and syringe would be used. However, this contaminated single-use vial was used on that subsequent patient. This outbreak was well publicized and continues to be in the news. This really came to the attention of the federal government. They realized that these types of facilities were not being routinely inspected, and so they did what they consider a blitz. They investigated 50 clinics in 30 days and found many breaches. None rose to the level of what was seen at this particular clinic, but there was certainly concern for disease transmission due to similar breaches. The physician who owned the facility lost his license to practice medicine and was arrested for criminal charges. Just recently, in July of 2013, the physician was convicted of murder charges. One patient died as a result of the hepatitis C infection. In addition, numerous malpractice suits were filed. The manufacturer of propofol was successfully sued due to the fact that appropriately sized vials of medications were not readily available, and it was alleged that the manufacturer was aware these single-use vials were being used for more than one patient routinely by such centers. As you can see, these kind of cases attract a lot of media attention. Oftentimes, an astute public health or healthcare provider recognizes that there is a problem when he or she identifies a cluster of unusual cases associated with a particular healthcare provider or facility. However, it is likely that these are single cases of disease associated with medical injections that are unrecognized. Here's a case control study that was done looking at cases of acute hepatitis B or C in New York and Oregon. The conclusion is that the healthcare exposures may represent an important source of new Hep B and Hep C infections among older adults. This chart shows that it's not just viral infections that are attributed to unsafe injection practices, but bacterial infections happen too. The CDC has recommendations for performing spinal injections. New Jersey had an investigation of strep salivarius meningitis following an epidural injection in 2011. It was determined that masks were not consistently worn during spinal procedures. Masks should always be worn during injections. Anyone performing spinal injections should review the CDC recommendations. Face masks should always be used when injecting material or inserting a catheter into the epidural or subdural space. Aseptic technique and other safe injection practices, such as using a single-dose vial of medication or contrast material for only one patient, should always be followed for all spinal procedures. This is a reenactment of how the nurse carried her face mask between procedures. Masks should not be worn on the elbow. They're not protecting the patient there. Masks should always be discarded after every case and new one put on before the next. This was a single case of acute hepatitis C. The patient had no traditional risk factors other than she had a surgical procedure and was a healthcare worker. Surgery took place at an outpatient ambulatory surgery center affiliated with a hospital. A chart review was performed of patients who had surgery performed on the same day. The chart review identified a patient with known chronic hepatitis C who had surgery prior to the index case. Commonalities included 2 surgical nurses, 1 anesthesiologist, and the anesthesia cart, and propofol. Only the anesthesiologist performed invasive procedures on both patients. Only common medication was propofol, and the anesthesia cart was used for both cases. Anesthesiology services are contracted at the facility, and there were not strong policies about recording what drugs were used and restocking the carts. That has since changed as a result of this case. Now we're going to briefly go over some drug diversion prevention facts. If you're more interested in drug diversion prevention, please contact JDJ Consulting for a longer and more specific in-service on this topic. Drug diversion means when prescription drugs are obtained or used illegally. When healthcare providers steal controlled substances for their own use, it can result in substandard care delivered by an impaired provider, denial of essential pain medication or therapy, and of course, the risk of infection if a provider tampers with injectable drugs. Here are some common ways we see diversion in action. There's false documentation. Medication doses are not actually administered to the patient or wasted, but instead they're saved for use by the provider. Sometimes there's scavenging of wasted medication, such as removal of residual medication from the used syringe bucket. There's also theft by tampering. Here we see removal of medication from a container or syringe and replaced with saline or other similarly appearing solution that may be administered to patients. This is a graphic that shows the mechanism of how an infected healthcare provider who diverts injectable medication can infect a patient. Reusing needles, syringes, or replacing medication with saline is a common method of diversion and drug tampering. These outbreaks revealed gaps in prevention, detection, or response to drug diversion in the U.S. healthcare facilities. Healthcare facilities should have strong narcotic security measures and active monitoring systems to prevent and detect diversion activities. Appropriate responses by healthcare facilities includes assessment of harm to patients, consultation with public health officials when tampering with injectable medication is suspected, and prompt reporting to law and other enforcement agencies. If you suspect diversion at your facility, be sure to contact your consultant pharmacist immediately. They will have more information about the reporting requirements in your state. The transmission of hepatitis C to patients in healthcare settings is well documented. Most healthcare-associated HCV infections represent patient-to-patient transmission of Hep C after breaches of infection control by healthcare personnel. Instances of Hep C transmission from healthcare personnel to patients are reported infrequently. However, we are now identifying Hep C transmission from infected healthcare workers because of narcotic diversion. These are the faces of drug diversion. This is a case study of a hepatitis C outbreak in Colorado from 2009. This is a particularly troubling case because in this situation, the surgical tech, whose name was Rocky Allen, pictured on the previous slide, actually traveled from state to state, acquiring employment in multiple healthcare settings, and continued to divert throughout this multiple year period. As you can see here, there were more than 8,000 patients notified and 26 documented infections from him alone. This is a New Hampshire case from 2012. Narcotics tampering is now the leading cause of provider-to-patient transmission of bloodborne pathogens. Drug diversion should also be considered when clusters of unusual pathogens are noted. Here are some key points about drug diversion. Healthcare facilities should always have strong narcotic security measures and active monitoring systems to prevent and detect diversion activities. You should understand how contractors deal with suspected or confirmed diversion. And there should always be appropriate responses planned by healthcare facilities. These include assessment of harm to patients, consultation with your public health officials, and prompt reporting. Please work with your consultant pharmacist to ensure that you have a plan in place to prevent drug diversion and to respond if it ever occurs. Infection control in healthcare has a long history. The recommendations are not new. The Guideline for Isolation Precautions, Preventing Transmissions of Infectious Agents in Healthcare Settings, is an important document. This document is easily accessed through the CDC's website, but it's over 200 pages long. This guidance document from the CDC includes a section on injection safety. I want to emphasize that this document applies to healthcare in all settings. There are additional documents to address minimum expectations for care in general outpatient settings and outpatient oncology settings. There is an accompanying checklist for general outpatient setting guidance, which is distilled from the original guidance. If you haven't seen these documents and they apply to your current practice, you should read them to determine if your practice follows the guidance. Many physicians in outpatient settings and in private offices may think that this doesn't apply to them, and many have no familiarity with this 2007 document. That's a problem because you don't know what you don't know. By taking a quick look at these documents, you'll quickly find out whether or not these practices apply to you. So what's being done about raising awareness for unsafe injection practices and to promote injection safety? A national coalition was formed, Safe Injection Practices Coalition, known as the SIPC. The SIPC is a CDC-led group that is made up of federal partners, the FDA and the CDC Foundation, as well as state partners and representatives from pharmaceutical and medical equipment companies, professional organizations, as well as the patient advocate group, HONO Reform. The coalition is tasked with raising awareness and promoting safe injection practices. Here are some takeaways from today's presentation. If you have any further questions, please reach out to me, Brittney Lodato, the Administrative Director of JDJ Consulting. I am a Safe Injection Ambassador from the New Jersey Department of Health. Similar programs are available in other states besides New Jersey. You should check with your Department of Health to see if there are reciprocal programs in your state and how you can become a Safe Injection Ambassador yourself. Have a good day.